a whirlwind tour of tick-borne infections in pregnancy here. And like I said, it's a complex situation because you've got the mother, you've got the child, and you've got the placenta. You've got lots of different immunomodulatory factors that are involved. And pregnancy is a state of immunosuppression. So there's changes in CD8s and CD4s and T1 and T2 helper cells. So it's quite a complex situation that we poorly understand. So what happens if you get an infection in pregnancy? It may just be a self-limiting illness. It could result in loss of the baby. It could result in an invasive fetal infection. It could involve damage to the placenta, and indirect damage to the baby because of placental insufficiency. It could result in a congenital syndrome. And the timing of infection might make a difference as well. It might be different if you get infected early in pregnancy or if you get infected at the end of pregnancy when you come out from delivery or through breastfeeding. So there's lots of different factors involved. It's quite complicated. And like I said, there's a wide range of different complications depending upon the timing of the infection, the host, the immune system, the invading pathogen, the inoculum of the invading pathogen. It's quite complicated. So this slide here just summarizes the different components of vertical transmission, and there may or may not be a congenital syndrome associated with different infections. So this slide actually shows kind of an interesting case, not Lyme disease, but this goes back to Boston Children's Hospital, 1977. So a child with this mystery illness, fever, malnutrition, moms with a history of drug use. So it goes back to 1977. So maybe you'll guess what this is, but this was a mystery illness in a child who had low lymphocytes, an actual overwhelming infection, hypergammaglobulinemia, and eventually died. So this is the pathology report on this child. And then eventually in 1985, we had an antibody test for HIV that was able to diagnose this child. So this was one of the first children born with HIV and AIDS. And we've had a great story with HIV and AIDS because we identified a mystery illness. We had a few case reports. We identified children, and then we put resources into better understanding this condition, the factors involved in pregnancy. And this is, like I said, the first case report in 1982 to the CDC of a child with what was suspected to be pediatric AIDS. We weren't able to diagnose it for sure till 1985 when the antibody test became available. And then we actually put together a study called ACTG-076 to investigate whether any treatment would work to prevent the mother-to-child transmission of HIV. This is ACTG-076, and it worked. First demonstration of treatment for prevention, and then we implemented successfully a treatment in pregnancy, and then all the children with HIV disappeared. 96% reduction, and this slide just shows all of the studies that have been done all over the world with resources and financing and support of the NIH and NIAID and NICHD, and we essentially have been able to eliminate and almost cure HIV and AIDS in children because of a few case reports and implementation and resources to effectively eliminate this problem. So this is what happened with HIV. We had identification of a mystery illnesses, investigation, case reports, prospective studies. There's studies called WIT studies, women infant transmission studies, that were put together. an intervention, ACTG over 076, and then a study that I did after that, ACTG 185, identified the factors associated with transmission, viral load, and now we've got rollout, we've essentially eliminated congenital HIV. So how have we done the same with congenital Lyme? What's happened in the last 30 years? What research has been done? How can we prevent congenital infections? What are the challenges? And then in the last couple of years, the ad hoc committee went to the WHO to get identification of congenital Lyme with an ICD-11 code, and I'll discuss that a little bit. So this is one of the first slides showing that Borrelia could be found in the womb and cause adverse outcomes in children. And this is Willy Berdorfer, who has one of the first case reports reporting a child who died with congenital heart disease associated with Lyme disease. And then there was a textbook, infectious disease textbook, Remington and Klein, published in 2001, 5th edition, chapter by Gardner et al., 888 citations, 263 cases of gestational Lyme, 660 cases representing adverse outcomes. So a big body of literature dating back early on regarding congenital Lyme. MMWR recognizing congenital Lyme as far as 1985. Cases out of Long Island, Alan McDonald from Southampton Hospital, reporting spirochetes in stillborns, publishing this on human borreliosis. Further cases by McDonald and Willy Berdorfer. Further reports from 1987, California, a pregnant woman, seronegative, child seronegative, but evidence of borreliosis from pathology culture, so culturing by and PCR test proof of borreliosis. And then these are further publications by McDonald showing Borrelia spirochetes in a baby who had died of what was thought to be SIDS, sudden infant death syndrome. So I'm just giving you kind of a whirlwind summary of lots of the early literature on data, mostly case reports and small studies on borreliosis. This is a study from 2010, maternal Lyme borreliosis and pregnancy outcomes by Ehrlichosis et al. And then this is data coming from Gardner, 2001, looking at the range of different conditions that were seen in the setting of pregnant women with Lyme and the consequences of Lyme infection and pregnancy to the child. So like I said, there's a wide range of different consequences, miscarriages, if early infection, congenital infection, late infection causing complications. And this has all been well described in the pediatric infectious disease textbooks dating back to 2001. This is another slide looking at a series of blood samples in spontaneous abortions in a Lyme endemic area, showing a higher incidence of complications in patients, pregnant women who are Lyme positive, for those who are Lyme negative. This is a case report of a child who presented at 9 months, I believe, and had biopsy proven skin lesions, over a period of years, so isolated and PCR positive for borreliosis. So the only exposure this child had to borreliosis was the pregnant mother. And then just to summarize some of the studies that have been done of Lyme disease in pregnancy, when they have treated Lyme disease in pregnancy with antibiotics, there's been reduced adverse outcomes for the fetus, 11% in one study, actually a study that's quoted by Waddell, versus women not treated for the infection in pregnancy. And then another study by Ehrlichosis et al. Reporting different treatments, IV versus oral versus no treatment. So the IV treatment in pregnancy, 12% adverse outcomes, orally treated, 31% adverse outcomes, and then untreated, so this was a misdiagnosis, 60% adverse outcomes. This is kind of a guidelines from the UK Royal College going back to 2010, talking about late intrauterine fatal death in stillbirths, looking at the different infections that are associated with that, including a number of different viruses and bacteria, including Lyme disease. And this is actually kind of a summary coming from the Centers for Disease Control, which are the results of the tick-borne working group report to Congress, basically reporting transplacental transmission of the human fetus, recognizing for a number of different borreliosis, including relapsing fever, borreliosis. And then the Government of Canada's report of Lyme disease in pregnancy, coming down on the other side, basically saying not enough evidence to confirm that Lyme disease during pregnancy has adverse effects from the fetus. No mention of in utero or transplacental transmission of Lyme disease from an infected mother to her baby. There's literature out there on Lyme disease in pregnancy and congenital Lyme. However, most of these, the description of complications of Lyme disease have not been included historically in the ICD-11 WHO codes, which resulted in Jenna and the ad hoc committee submitting a proposal to get a number of new Lyme-related conditions approved for the next round of ICD-11 codes. And indeed, this was successfully achieved by submitting the scientific data, limited as it is, on congenital Lyme. And there was a conditional approval in June 2018, given congenital Lyme borreliosis, an IC1C1G.2 congenital Lyme borreliosis, which was a major achievement because there's lots of good reasons to have a standalone code, because it allows an opportunity to move forward with better understanding, prospective studies, and able to kind of categorize the disease. However, in December, as many of you know, Jenna discovered that when she checked the WHO website, that the code from congenital Lyme had been removed. So the other codes, which were newly added, were left, but congenital Lyme borreliosis was deleted without the knowledge of the ICD-11 code. And why was that? About a month before or 2 months before, a Canadian group, mostly not clinicians, mostly public health people, had put together what they called a systematic review of the impact of gestational Lyme disease in humans on the fetus and newborn, and basically questioned whether there was evidence of transplacental transmission, complications, et cetera, really deleting many of the cases that had been included in Remington and Klein textbook and much of the world's literature on congenital Lyme. Subsequently then, Jenna queried the WHO and basically was told that the new ICD-11 code for congenital Lyme had been removed in response to a request by the Public Health Agency of Canada, who stated there was little evidence of a specific syndrome resulting from congenital B. burgdorferi infection, in contrast to congenital syphilis. So this was the rationale given by a member of the WHO for removal of this code. However, there is no congenital syndrome for malaria, but congenital malaria and pregnancy has a standalone ICD-11 code. You don't need a congenital syndrome to have an ICD-11 code. The issue is there an infection that spreads from mother to child, and is there adverse consequences of that infection from the baby having Borrelia? And the answer is yes, and that in itself is the reason for the code. So we have pursued trying to get the ICD-11 code put back on the stable code, and we've actually written to the WHO. We've submitted letters to the Lancet for publication, but unfortunately, there's been no communication back from the WHO in response to the open letter that we've submitted. Additionally, the request to publish a letter in Lancet was refused as well. Just previous year, Lancet had accepted a letter, correspondence letter on HTLV1, very similar to this, but they declined to agree to publish a letter regarding congenital Lyme. So the Waddell systematic or non-systematic review, the timing of this publication in relation to the WHO ICD-11 codes is quite concerning. But if you look at the systematic review from Waddell, it's non-systematic. Much of the world's medical literature was discounted. They said, we don't look at case reports. They deleted Willie Burgdorfer's case, poor Willie, because they said that the ECM rash was not seen by a GP. It was just reported by the patient, so they couldn't include that in the review. And then, like I said, there's questions as to whether the systematic review by Waddell should have been used as a criteria for removing the ICD-11 code. However, finally, a number of European MPs and TDs and others sent a letter to the WHO, and just on the May 11th, 2020, Dr. Samira Asma, Assistant Director, responded. And she responded on behalf of one of the fellows that I tried to correspond with, Dr. Jacob from the WHO. And she basically said, there needs to be sufficient evidence that a health condition exists. The concept of congenital Lyme disease was removed from the ICD-11 based on a different story, a systematic review conducted by the UK NICE. The decision was later also supported by an independent systematic review by Waddell et al. And information available from the CDC. Now, the CDC actually have on their website that there is such a thing as congenital Lyme. And as you know, the UK NICE decided only to include PubMed articles from 2000 and beyond, nothing before. And most of the literature on Lyme disease, both in terms of chronic Lyme and in congenital Lyme, predates 2000. And so this continues to be a challenge. Dr. Samira Asma then said, when future research would provide evidence for congenital Lyme disease, a proposal for amendment of ICD could be submitted. So here we are, going round in circles, chasing your tail, getting nowhere. So this is the challenge of congenital Lyme. I was involved in the forefront of work with congenital HIV, but we can't get anywhere with congenital Lyme because it doesn't exist. I just wanted to mention a few other congenital tick-borne infections, as part of this. So anaplasmosis, how common is it? Well, we don't test for anaplasmosis, so we don't really know, but there are case reports of perinatal transmission of anaplasmosis in the literature. And Ehrlichosis is one of the conditions, and anaplasma and Ehrlichiae both cause problems in pregnancy, associated with neutropenia, associated with lymphopenia. And as I said, there's been a case of miscarriage following vertical transmission of Rickettsiae in pregnancy. Cases of Babesiosis, very few, small case reports. And like I said, usually only reported as microti in the US, but we're not testing for divergence in the European Union. It's thought to be more common in immunocompromised, and as pregnant women are immunocompromised, there appears to be an association with the HELP syndrome in pregnancy, which is kind of a condition associated with thrombocytopenia. And there has been suggestion of a congenital syndrome with fever, thrombocytopenia, and anemia in the few cases in the world's literature reporting babesiosis in pregnancy. Tick-borne encephalitis in pregnancy, another tick-borne infection caused by a virus. The few cases of pregnancy-associated tick-borne encephalitis have not shown severe complications or complications to the baby. Relapsing fever in pregnancy. In the third world, relapsing fever, Borreliosis is thought to be a significant problem, thought to cause up to 10 to 15% of neonatal deaths worldwide. What is the burden of disease within Western world and North America, in Europe? We really don't know. Most studies have showed problems with impaired fetal circulation, direct invasion of placenta, and if you don't have a good placenta, then you're going to have a baby that's malnourished. And there are, at least in animal studies, evidence of intrauterine growth retardation associated with relapsing fever. But it's not been well studied, but anecdotally from third world studies, it appears to be a significant cause of neonatal morbidity and mortality. Rickettsia, other Rickettsia, Rocky Mountain spotted fever, a very lethal disease in North America, very often kills the mother. If the mother dies in pregnancy, then the baby dies as well. But it's not been well studied in terms of vertical transmission. This is a case of Bartonella and perinatal transmission, and so there's very little data on outcomes of the baby. The only condition that Bartonella in pregnancy, as was mentioned yesterday, from ticks, but also from fleas, lice, and flies, and the only condition that's been well studied is Carrion's disease in South America. Very few reports of vertical transmission, but if a woman in pregnancy, there does appear to be high mortality, miscarriages, preterm births, and fetal deaths in the setting of acute Bartonella, Carrion's disease in pregnancy. So I just gave you a whirlwind, a tour of tick-borne infections in pregnancy. The challenge is there's possibly a shortage of well-designed prospective studies, little investment in the accurate surveillance and monitoring of these infections, worldwide. My opinion is having an ICD-11 code, and the code is IC1G.2, which has disappeared from the WHO lists for congenital borreliosis, would assist in the ability of researchers and advocates to petition for better studies and better funding. The ICD-11 code was dropped from the NICE reviews that only included publications from 2000 and over, and the Canadian paper by Waldell is not comprehensive, but is a selective and cherry-picking exercise in reviewing the literature. And in order for us to kind of move forward and understand this condition, we need to develop prospective studies, monitor pregnant women, and follow the babies, the mother in pregnancy and the babies after delivery, kind of a Lyme-WITS, woman-infant transmission study. This is what's going to take to move forward with understanding this disease. What are the consequences of misdiagnosis in pregnancy? You know, we're probably missing many unknown cases of tick-borne infection transmitted in pregnancy. You know, there is anecdotal data out there that autism spectrum disorders is possibly a result of vertically transmitted infections. Kind of studies done in the US states where Borrelia is more common. Autistic disorders are much more common compared to states which have very few Lyme cases. There's a mystery childhood illness called spinal muscular atrophy, similar to ALS, which is attributed to Borrelia. So we don't know. There may be a lot of occult tick-borne infections in pregnancy, negative antibody tests in the mother, negative antibody tests in the baby, as we know, and then we may not show, the babies and children may not show complications for years and years after birth. So Tessa Gardner, who led the work on congenital Lyme in her publication in Remington in 2001, basically says serology is not a sensitive method. We know that. It's not good in non-pregnant individuals. It's probably even worse in pregnancy, because pregnancy is a state of immunosuppression. Heterogeneity, there are some sort of leads that there may be some heterogenetic complications, including cardiac abnormalities, but it doesn't matter if it's a congenital malformation or congenital infection that results in complications in utero or after delivery. It's important to better understand these conditions. And what we need, as Tessa says, is large-scale prospective studies and long-term follow-up of the infant to look at the potential sequelae of these infections, similar to looking at chronic fatigue syndrome patients who are followed up long-term on treatment. Do they get better? Do they not get better? The Columbia group have followed these patients long-term. It's important to do the same for this population. So in summary, does Lyme disease spread from mother to child? Yes. It's transplacentally transmitted and it causes adverse outcomes. We have only small studies, but this bacteria spreads the placenta to the baby. Is it likely that early in utero infection causes more severe damage? Probably so. This is exactly what happened with HIV. Placental insufficiency, large volume bacteremia may be important factors. One of the findings they found in the pathology is a lack of inflammation in the pathology specimens in the placenta, but that doesn't mean that the infection doesn't go to the baby, and the inflammatory response may happen after delivery or years later. So I would kind of support that having an ICD-11 code for genital Lyme would really facilitate the recognition and better prospective studies and encourage future research. Long time ago, when I was training in America, I actually showed up the doors of the NICHD, the National Institute of Child Health and Development, basically for a new study on HIV. I was well received. About 6 months ago, I contacted my same contacts at the National Institute of Child Health and Development in the Division of Maternal Health and asked if he would be willing to kind of take the banner up on congenital Lyme. His response was, I would love to, but the Pediatric Red Book, which is the Bible in America that pediatricians use, doesn't even have a listing of congenital Lyme. So until we have recognition of this entity, we can't get buy-in from the establishment, we can't get research. So I think science has lost the day to date, and I think Jenna and the advocates really need to push this agenda. So if we dealt with HIV, if we dealt with HIV like we have Borreliosis, we still would have a pediatric HIV epidemic rather than the success that we have. We need to find a way beyond this barrier and better understand, what's happening in the dyad of the mother and child infected with Lyme and tick-borne infections. And finally, this is a slide from Dr. Spector from Duke University, who recently passed away. He gave me this slide. This is a very complicated condition, and there's many factors involved. And rather than denial, we need best minds, best science, and lots of money to tackle these conditions. Thank you.